Thank you very much, Mr. Chairman. It is my pleasure to be here. And thank you to Professor Ahmed for giving me the honor to be with you. And I hope I can. All right. I was pleased that Professor Adam and Professor Hayam made the stage for me because two things which is important from the clinical point of view is about CAMPATH, because it is related to what we call it the indirect pathway of chronic rejection and the helping intolerance, and about the issue of chronic antibody-mediated rejection because it is still related to these indirect pathways. So the topic of today is about allorecognition and chronic rejection. And the agenda includes the importance of this subject, why we are speaking about, definitions, because we cannot speak about the allorecognition without knowing what is it and what is actually chronic rejection, the terminology, and what is the difference between CAN and transplant glomerulopathy and IFTA, and the introduction and the pathogenesis and pathophysiology, the mechanisms, including many things, allorecognition pathways in a transplant rejection and tolerance, what is the direct and indirect and semi-direct, and why do we reject a graft, and the role of a direct allorejection in a graft rejection, and the mechanisms of allorejection and organ transplant rejection, and the role of this indirect allorecognition in chronic rejection, which is the main story of this talk. But maybe I will start by a debatable issue, but still we have few slides, only I picked 2 or 3, about the future. What is the clinical relevance of this topic, because it is a rather basic things. And the administration of a Treg and the dendritic cells and almutizumab. And my last statement. The coming 3 slides will be a little bit basic, but actually this is the debatable conclusion. Allorecognition pathway in a transplant, rejection, and tolerance with the advent of cellular therapies. That's why this issue started again. It has become clear that the success of future therapies in prolonging allograft survival will require an intimate understanding of this allorecognition pathway and the effector mechanism. Because as you know that the acute rejection episode diminished less maybe than 5 to 3%, but the chronic rejection, whatever we call it, and we shall come to this in a minute, is still high. The current understanding of these T-cell allorecognition pathways, and the most likely the mechanisms by which these pathways collaborate with other effector mechanisms, and the development of a new strategy. Although both direct and indirect pathways, CD4 T cells, appear active immediately after transplantation, it has emerged that this indirect pathway, which even the dominant alloreactive T cell population in chronic rejection, and the ability to provide help for generating long-life alloantibody is likely one of the main mechanisms for this. And the regulatory T cell is one of the important. So giving these things, the adaptive therapy with CD4 regulatory T cell, with indirect, what we call allospecificity, is the rational first choice in attempting to make better graft and less graft rejection. What is the importance of this? Because there is inherent ability of this host immune system to distinguish between self and non-self forms what is the basis of allorecognition. Consider the self and non-self. And it is actually the T lymphocytes, not the B, which constitute the most important effector of this. And the transplantation between non-identical members of the same species elicit an immune response that manifests as a graft rejection or better as a persistent. And this presentation of this foreign antigen to recipient T cell can occur by 3 non-mutually exclusive routes, the direct and indirect and semi-direct pathways, and actually each of these pathways has implication clinically. The allospecific T cells can have effector or regulatory functions, all of us know that, with the relative proportions of these two populations activated following an alloantigen presentations. And still, after transplantation, this recipient T cell can recognize the donor antigen either by interacting with a major histocompatibility class 2 on donor bone marrow derived cell. This is the direct allorecognition, a picture will come soon, or by recognizing an alloantigenic peptide bound to self class 2 molecules on a recipient antigen. And this is the indirect allorecognition. And this activation of the pro-inflammatory T cells via either these pathways lead to what we call it rejection with suppression of both these pathways. And coming to this coming 5 slides, which will open fire on me, that's why I searched many things, but I was thinking that the best is to come from the up-to-date, something which you cannot disargue, and actually most of it supporting what I actually believe, although I'm believing wrong or right. So what is the difference between, we cannot speak about chronic rejection without defining what is chronic rejection. A terminology actually 10 years ago was vanished, then come again, for example in the transplantation 2013, raise again. So this is actually updated till February and from February 2013. And just look to the base of the slide because you can recognize these people actually. Sorry. You can recognize these people, the names of Brennan and Murphy and Sheridan, which is an eminent nephrologist. They speak about renal allograft failure. It's one of the most common causes of end-stage renal disease. About 20 to 30% of patients awaiting transplantation. Similarly, over 20% of the kidney transplant, second transplant, is due to this failure. And the most common cause of this graft failure after the first year is incompletely, and that's actually what they said, incompletely understood clinical pathological entity called chronic rejection, you can call transplant nephropathy, chronic renal allograft dysfunction, transplant glomerulopathy, chronic allograft injury, or referred in this topic actually as chronic renal allograft nephropathy. They all of them used instantaneously the same, but they are actually not the same. And still, the revised PANF 2005 renamed this chronic allograft nephropathy, as Professor Hayyan mentioned, interstitial IFTA, without evidence of any specific etiology. And this was done because the term chronic allograft nephropathy, the old terminology, replacing the chronic rejection 10 years ago, was thought to diminish the attempts to determine the underlying cause of histological. We actually know something about the etiology, so we repeat the terminology again. And the band 5 also added the term, as Professor Hayyan mentioned, chronic active antibody mediated. And actually this is through the indirect pathway, characterized by C4D and different things. And they said, although the term chronic allograft can, which we, if anybody mentioned can, it means that this is ancient, actually not, may be inaccurate, the newer attempts actually to do terms do not seem to produce a significant improvement, which we have retained in this topic. Actually, this is what they said. That's why I remain the same words. So the pathological changes of this chronic allograft, renal nephropathy, whatever, involve all parts of the renal parenchyma. There is a little bit discrepancy, a little bit evidence between transplant glomerulopathy and chronic rejection. And this is for this whole picture coming from the up-to-date. If you find this chronic vascular things, this is, you can call it chronic rejection. And this is the same in the vascular. But if you found, and this is the extensive chronic rejection, but if you go, as they said, at a transplant glomerulopathy with this double contour in comparison to this normal glomerulus, and this is actually the transplant double contour of the membrane in comparison to this is a transplant glomerulopathy. And they actually classifying these, and although the vascular and the glomerular finding may be more specific for one disorder than the other, but actually they're interchangeable. And the histological evidence of chronic nephropathy using different versions of this system may not be 100% precise. But look to this paper coming from 10 years ago, because they mention 95% survival, 82 and 41. And the difference is actually vascular, which is chronic rejection. Because if you got no parenchymal or nothing, it is 95. If you got glomerular without vascular, this is 82. If you got vascular, which is the picture of chronic rejection, it will be 40%. So, if you go to the reference of this article, look to this. They are coming from 10 years ago. The word chronic rejection was, at least 5 years ago, was banished. And then they started again as I'm going through, because we do have some mechanism to give us the opportunity to say it as chronic rejection. So the differential diagnosis, I go with this because just to, you might think about kidney dysfunction, different things, and including membranous proliferative GM, and but the comparison is different, but this is actually because of the time, and the interstitial fibrosis, because we're thinking that this is related to cyclosporin, but actually it is not as we believe, it is merely cyclosporin. But things to think about, if you found glomerulopathy or glomerular basement membrane splitting or lamination, this may be with a rejection or CAM. If you have a newly formed hyaline arterial changes, this is maybe with cyclosporin. But actually these new things may not be apparent from the start. And what is allorecognition? So the chronic rejection, you can differentiate it between transplant glomerulopathy, but still in the context we are not 100% sure. But that's why in this transplantation article 2013, we raised the topic again, chronic rejection, because we know about allorecognition, which is actually 5-10 years, but it is coming on the surface. So these T cells appear to recognize this measure histocompatibility either directly or indirectly. Simply, directly they see the antigen on the cell, but the indirect, the antigen going inside the antigen progenitor cell, and this will be changing, but still see. They claim, many literature, that this indirect pathway is related to the chronic rejection, because the direct is vanished, but actually this is not a 100%. The semi-direct is the antigen going inside the cell, but it's not changing. And that's why they call it semi-direct. So the semi-direct has been proposed where alloantigen is internalized by the recipient APC, and instead of being processed, being intact on the cell surface. And this is different profoundly. And as you see, and this is the things which I want from this picture, because it is related to a humoral alloimmunity. That's why the issue of chronic antibody-mediated rejection came on the surface 5-10 years ago. We do know something related to the indirect pathway and the chronic antibody-mediated rejection. And I will pass through this because respecting the time and going to the areas of expectation, the prospective contribution of this direct and indirect pathways to acute graft rejection, and this role of indirect in the development of allograft vasculopathy, which is the main bulk to say chronic rejection. And this indirect pathway, CD4 T cell, can theoretically mediate a late graft damage by acting independent effector cells. And Nevertheless, despite the definitive experimental evidence of this data, there is still some controversy about using this semi-direct pathway in the rejection. The CD4 T cell actually allorecognition contribute to acute rejection, which is not in our, and chronic rejection. And the same story, it is the longevity of this direct and indirect allorecognition in the chronic rejection and is related to the indirect pathway. I'm just going through this so as to, for the time being actually, and even assuming that only CD4 T cell alloimmune responses are active at late time point, how they mediate the development of chronic rejection is still not yet clear, although most of the authors believe that the indirect is responsible about chronic rejection. I will go. So this is actually the different types of the cell and how these indirect CD4 cells affecting the recipient ABC cells to produce what we call it a chronic allograft vasculopathy as a part of the chronic rejection. And of course this is related to tolerance. So is it the direct or the indirect? And the contribution of the direct and indirect allo responses to chronic rejection of kidney allograft in non-human primates. And this actually, a TMP cell study on cynomolgus monkeys that had received combined kidney and bone marrow graft, no indirect allo response by the T cell was found, but one of the monkeys, one of the 4 monkeys, has still a direct related T cells. So the direct in this study only may be incriminated to be related to what we call it chronic rejection. The coming 3 slides is a clinical application or part of this. Almutizumab induction in pediatric kidney transplantation in 2013. This, we know that the recipient parenchymal lymphatic cells are crucial for this direct and indirect. Almutizumab infused several weeks pre-transplantation to eradicate the peripheral lymphatic cells and promote donor-specific tolerance. About 2 doses of 30 milligram, and they showed diminished CNI and diminished indirect pathway. The other thing that if you perfuse what we call it CD4 plus CD25 FOX3 plus indirect alloreactive T cell from a renal transplant, it suppresses both the direct and indirect pathway. And another paper coming a couple of years ago in the European Journal of Immunology that the road to transplant tolerance is paved through a good dendritic cell. This dendritic cell modification causing decreased indirect pathway helping to cause intolerance. So, Mr. Chairman, allow me to say my last statement about this topic. In the allorecognition pathways include direct, indirect, and semi-direct are important in induction of tolerance. And the indirect is more related to chronic rejection. And the Treg therapy and the dendritic therapy and almutizumab may be potential therapeutic option. However, it is still early to use this knowledge in a real clinical practice. And thank you very much.